really neat thing happens spatially. The immune response is actually ringing about the necrotic areas, almost encapsulating them off. And so this is something interesting that we're trying to look into. Okay, moving forward, and remember this is just the first example, sorry. First thing is to acquire temporal immune response data. We have one data point, that's not enough, we all know that. For all we know, immune response is doing all kinds of crazy things. We don't know what's happening. This is actually ongoing. It's being collected right now. I have a graduate student, and she's doing more than just general immune response. She's able to actually look at the individual cell populations, so that's really exciting. I'm advising her on how we're going to expand the model, kind of take those, now that she has data in time for each of those populations, because it could be that different populations are focusing on different pieces. Explicitly incorporate therapy. That might feel a little awkward at first. I thought therapy was in this model. It's not, right? It's implicitly there, right, when we did the parameter calibration. Otherwise, therapy is not here. That makes it really hard to optimize therapy, doesn't it? So the idea is we need to incorporate this, and this is very important for this particular system too, because the order and timing of therapies of trastuzumab with other chemotherapies, cytotoxic therapies, can have a huge impact. So here, this is doxorubicin with TMAB. The top line is dox applied 24 hours before TMAB. The bottom line is where TMAB is applied 24 hours before dox. So clearly, the order and timing of these drugs is very important. So we really want to look at this. And so part of the way we're thinking about doing this is extending the model to multiple scales, leveraging in vitro data. So just to remind you what's going on here, this is in vivo. We have a mouse system, it's alive, we have tissues. The in vitro scale is where you're looking at cell confluence, and you're thinking about the cell scale where you can have different dynamics of different drugs. Here you're actually seeing paclitaxel. We had to make a switch. Turns out dox and TMAB together causes cardiac issues, so they stopped doing that. Remember, trial and error. So they stopped doing that and do TMAB with taxol. And so the idea is we can write down equations. This is all but submitted. I just got the final author's edits back on this. So we wrote down some equations for this as well, where we're looking at how these drugs are affecting the carrying capacity and growth rates at the in vitro scale. And the hope, genuine hope, is that we can couple this information back to the in vivo scale and try to do some therapy testing with the in vivo model, based on everything that we've learned from the in vitro scale. There's going to be some translation issues, of course, delivery of drug, washout, other things that you don't have to consider at the in vitro, but this is kind of one of the things that we want to try to do moving forward to, again, to that goal of optimizing therapy and figuring that out. Okay, so this is the end of the first part. If you're okay with it, I'm just going to jump right into the next part because I really don't want to slight the next part. This is a really cool part. This is a spatiotemporal model for clinical breast cancer data. So this is patient data. Okay, everyone okay? Nods. All right, let's go. So the overarching goal with this one is we want to build a math model that utilizes patient-specific data to try and predict response to neoadjuvant chemotherapy. Neoadjuvant means any therapy before surgery. Okay? So the idea is you collect some data from the patient. Just to orient you, you're looking basically down on a patient. So this is her heart and the two breasts, and then you have the tumor in one of them. So you take some early time point data, you calibrate that model, you simulate the model forward, and you say, okay, how bad is that simulation? Did we do a pretty good job? And sometimes we have imaging, other times we have things like pathology from the surgery that we can compare our results to. So what is the data exactly? What this is MRI data, DCE again, so you already know that one, dynamic contrast enhanced, but also diffusion weighted data. So the DCE data is used to find the ROI, so the region of interest, because we have that enhancement, right? From there we can find those physiological parameters about the vasculature again. And then we use that ROI to look at the diffusion weighted data, which we create a map of something called the apparent diffusion coefficient. And that's the apparent diffusion coefficient of water. So water will diffuse faster or slower depending on the density and cellularity of the tissue. And this has been well studied, and there's a nice little formula that you can use with this map to then approximate the amount of tumor cells that you have in that tumor. And this is an interesting tumor because actually 80% of it was necrotic. So you can see in the middle there was really just fluid. no cells there. Okay, so what's the mathematical model? So this is a PDE. So we have N is the number of tumor cells distributed in space, so this is a 3D model. The middle term, I like to start with this one, is logistic growth. And so we have some information that we can help to calibrate the model to kind of limit some of the different values that we're getting. So for example, for the carrying capacity, we know the size of the voxels within the MRI. We know the approximate sizes of the cells, and we know their approximate packing density. So we can put a limit on that. It's also a spatially defined parameter, so we're doing this for each individual voxel within the tumor. It actually used to be the other way around when I first came on board. Proliferation rate was local, and the carrying capacity was global. But sensitivity analysis revealed that, this is, we were having issues with the calibration actually. And so it turns out that when we move the carrying capacity to be local, we have a little bit better, more control over the calibration and getting things to converge much more quickly. The second part, a few of you will find very cool. This is the diffusion term. And we actually mechanically couple this to the tissue properties. So if you look at the breast, there's these white lines and then some black. The white is actually fibroglandular tissue, and the black is adipose tissue. And these two different tissues have different stiffnesses. So the idea is, that as the tumor is growing, we should account for these different stiffnesses. So I'm not going to go into the details of this, but basically we have, we're using the von Mises stress, and there are people actively working on to make sure that this is an accurate way to model this. And then we have a linear isotropic equilibrium, elastic equilibrium here, that basically it's trying to balance out the outward growth of these tumor cells, where U is the, I don't have U in this version of it, but basically the outward growth of the tumor cells with the stiffnesses of these other tissue properties. And I'm happy to talk about this after, but I'm going to move forward. The reason why is I really want to get to the cool part, which is the treatment term. So what we have here, sorry, yes?
We're allowing the tissue to deform?
The tissue, yes, we're allowing the tissue to deform, basically. So we're looking at the stiffnesses, and we calculate the force vector that's coming out from the tumor cells, and we're saying the tumor has to adjust to what the tissue is doing. The different
So there's a field for where things started?
Yes, so we calculate it as it simulates, absolutely. Okay, so here's so we have alpha, which is the efficacy of the drug. This is a parameter we just calculate for each patient because it's going to be different. We have concentration of drug in the tissue, and then we have the number of tumor cells, of course, this interaction. The thing about this term is concentration of drug in the tissue, unless you're really good at it and you have some really cool drugs, you don't know what this is for any patient. We don't know how much drug gets into the tissue or where, how much, we don't know. So we had to make a guess. So we actually turned back to the DCMRI data, where there's a whole slew of literature on dynamic contrast enhanced MRI, and there's something called the extended Ketty-Tofts model, and what it is a two-compartmental model between the plasma space and the tissue space for the contrast agent. And that's actually where we get those parameters, K trans V and VP, the fitting of that model, understanding the arterial input function of the contrast agent going into this plasma and the tissue. So what we do is we steal those parameters, and instead we insert a population-derived curve for the drugs that we know these patients are on and their dosages. And what this does is it's wrong, right? But it gives us a first approximation of how much drug is actually getting there and where. So the idea was, okay, let's try this. Let's see if it does anything. It helps, because before we didn't have drug even in the equation at all before I got there. And it actually reduced our errors by around 50%. So we said, wow, okay, let's see what happens. What the overall goal, remember, is to calibrate our model and try to see if we can make predictions about whether or not these patients will respond. Okay, so if that's what we're trying to do, we have to speak the lingo of the clinical people, right? Assessing and predicting response. The model wants to predict response. What they do in clinical land is assess response. They can't predict response. If they could, we wouldn't have trial and error. So what they use in breast cancer is something called RECIST, which is the response evaluation criteria in solid tumors. And this is incredibly rudimentary. It's going to make everyone in here uncomfortable. So they divide these into 4 different categories: complete response, partial, progressive disease, and stable disease. And what they do is they take a CT scan or an MRI and they measure the longest axis of the tumor. And they say, okay, did it disappear? Okay, then that was a complete response. 30% decrease, okay, that's a partial response, progressive disease, 20% increase, stable disease, everything in the middle. This is how they assess response, which is, yeah, like I said, incredibly rudimentary, but we're trying to speak their language, so we said, okay, well, let's try and see what the model can do with this. For the results I'm showing you right now, it's an incredibly small set. This is just a cohort of 9 patients. I can tell you that the goal is to get to 100 to really assess what the model is doing. Right now we have 23 patients that are complete and several more enrolled, so this is ongoing, okay? But the results you're about to see are just for 9. And for this 9 patients, this is basically the scanning schedule along with their therapy. So standard of care for any breast cancer patient, well, not any, most breast cancer patients are to have 2 different therapy regimens followed by surgery. So that's what the 2 different colors are. So what we did here is for scan 1, this is before any surgery, or sorry, any therapy. Scan 2 is after the first cycle of the first therapy. Scan 3 is at the completion of that first therapy. And then scan 4 is after 1 cycle of the second therapy. And then we also have information from their surgery, their pathology report. For those of you curious or know cancer stuff, these patients received AC and Taxol, so AC first or Taxol first depending on, and 2 of the patients received carboplatin. This is a slide where I pay homage to all of the things I cannot mention that come with the acquisition of this data and processing of this data, which is its own project in itself. To be able to use this data has a lot of processing that has to happen. So just the registration alone of these data is really, really hard. But what you can see here is that the model has to handle some different domains. So different breast shape, different tumor shapes, different tumor sizes, different cellularity. There can even be different times between the different scans depending on their schedules. So these are all, this is what you'd be able to handle if you want to do individual patient predictions. And then we decided to evaluate the model in 3 different ways. So the first one is kind of what you would expect. So we want to calibrate the model and then try and predict this later scan. Okay? So we want to see how well it can do. So for the time of scan 3, actually there were 2 patients that are already complete responders according to the MRI. That means there's no tumor there. So to calculate error, division by 0 is still forbidden, the last time I checked, so we can't really use those. So we have 7. And you can see that the errors, so we have 23% and 69. And for this volume one, we weren't surprised that this was large because it's very easy to get this wrong, actually, the volume, because we're talking about voxels that are 5 millimeters thick. So if your model predicts that there's 2 voxels with tumor and the MRI has only 1 voxel, it's very easy to get the really high error for the volume. But looking at this, we said, okay, cellularity is what we want to use moving forward. These are just some examples of simulations. These are neither the best or worst, but they kind of give you a good view of what's going on. So we have 1 patient and another patient. The first column is their actual scan, where you see the anatomical image with the cellularity overlaid. And these are 3 slices. So these are big tumors, remember 5 millimeter slices. And then this corresponding model simulation next to it. This patient on the right, this is not a tumor, this is actually a breast implant, so we have to deal with things like that in our model domain. And so you can see that there's many, many differences. There's differences in cellularity and shape, but there's also spots where the model's getting it right. And so these are different pieces that we're looking at to try and improve the model's performance, and I'm going to talk about that at the very end, what we're doing to move forward with that. I just wanted to show you what the model's doing. And then moving forward, we wanted to compare RECIST, right? So what happens is we did the RECIST evaluation where we looked at no therapy to the completion of therapy. And luckily for this group, it was actually really simple. When we do that evaluation, we had 2 complete responders, like I said before, and then the rest were actually stable disease. So you can kind of see an issue with RECIST already, right? So a lot of things get labeled stable disease. And actually, in the clinical literature, they like to relabel these as, why we have to relabel them, I don't know, but we have PCR and non-PCR, so pathological complete response. So here are the results of what the model is saying for these 2 groups. Alright, so what do I mean by that? What is the model saying? So remember, we calibrate the model and we predict scan 3. So what you're seeing here is what the model is predicting for the percent change from the first time point to scan 3. The model's prediction. So over here, what you're actually seeing are medians and the full ranges because these are so small, there's no point in doing anything else. So over here, you're literally seeing one patient versus the other for the error bars. But over here, this is the max and min for the full set of 7. And you'll notice that they are totally separate, right? They're not overlapping. So this was exciting, and we used a statistical test for comparing the medians for really small sample sizes, and there is some significance. And I can tell you now that after evaluating more patients and adding more to the cohort, the statistics are holding up as we add. So this is extremely preliminary. The results are still very preliminary, but we still are seeing the trend. So this is really exciting. And the reason why it's exciting is, remember, the model only used information after 1 cycle of therapy and then predicted an outcome. If we can say whether or not a patient is going to respond to therapy after just 1 cycle, that gives us the opportunity to intervene. If we know they're not going to respond, or we have any inkling that they're not going to respond, that gives the doctor, or the MD, the oncologist, a chance to make a change. And the final one, because we just wanted to see what would happen, is we updated our calibration with scan 3 and 4 information and said, okay, can we predict what happens at surgery? And this is a little messier. We have 3 complete responders by that time, 4 partial response, 2 stable disease. Again, we relabel into 2 groups, PCR, non-PCR. And just so that you know, probably this audience isn't aware, if you have PCR versus non-PCR, there's a huge difference in their 5-year survival rates. Okay, so if a patient has no tumor at the time of surgery, which unfortunately they do the surgery anyway, then they take out tissue and they say, oh, there's no tumor left. They still had to go through surgery, right, the patient. That's really not okay. But those patients that achieve that PCR response, they're unlikely to have any issues in the future. Whereas anybody that has any residual disease, we have to watch them very carefully. So that's why we make that really, harsh distinction. And so here you can see that we have these 2 groups. Again, these are really small statistical numbers, but I can tell you that as we've added more to the cohort, this is actually separated more. And we're seeing that there's a significant difference between the groups. So that's very exciting for us in this group. But just, I've already kind of moved on. As you can tell how I am, I'm a modeler, right? I want to know what we can do next. So again, we continue to gather data for this. We're going to continue working on this. But I want to talk about what we can do to improve the model. So the idea is that perhaps we need to evolve the vasculature. And we've actually done this already for a preclinical model. So I'm working with another postdoc over at UT where he has a preclinical glioma model in rats, so gliomas in the brain. And we've already done this for his model. It's a similar model, they just have radiation therapy. There's some other issues because it's brain and their skull. And actually, it's kind of an easier problem because you have more data. Because it's preclinical, you can do whatever you want to rats and not to humans. But the idea is here, you probably noticed when I showed this to you, that there's a very dramatic change that can happen between scans, if you see the picture. The vessels are being affected by the chemotherapy. So this is the idea that perhaps if we can evolve that vasculature and the distribution of the drug, we can really get a better prediction coming out. Also, kind of stemming from the land of the in vitro, in vivo things that I've been doing is we want to incorporate more drug-specific mechanisms. So in this model right now, it's just kind of an explicit death term, right? But we know from in vitro and in vivo studies that that's not really always the best way to model this. Depending on the drugs that you're looking at, you may want them to modulate proliferation versus carrying capacity. So for example, a drug like paclitaxel, the way it works is it depends on the proliferation of the cells. Taxol goes in, and when the cells are dividing, called mitosis, they have these microtubules that help them push each other apart. And what happens is Taxol comes in and actually stabilizes those microtubules. And that's what causes the cells to arrest, and they die. That's not really true. It turns out sometimes they'll just divide wrong, but if it's done correct, if there's enough Taxol there, the cells will actually die. And so paclitaxel is not a direct death. It affects the proliferation, and it depends on whether or not the cells are proliferating. So you have to try and model that a different way. So the idea is that if we can then begin to put in specific mechanisms here, you can distinguish between therapies and then perhaps even optimize it.
There's one thing I'm not sure I understand with this model is that you're doing a diffusion, but isn't I mean the dead part inside the tumor, nothing comes back in it, does it?
In the model itself, or
well, in the
in
model
general?
it would. In
So
reality,
in biology, tumors will do different things. Sometimes you'll have a very diffuse tumor, so if some things die in the middle, then, you know, if it's a diffuse tumor, then you might have vasculature there and immune response and things can get in to clean things out. Other times you have more encapsulated tumors and they can actually, so for example, the first one I showed you with the necrosis, that one, as it shrank, the necrosis stayed. And so it, like the outer layer kind of went away and it just ended, in the end, it was just kind of a layer around this gross necrotic core, basically.
But so there's no diffusion in that region.
For for that particular tumor, and we don't really know why that happens or why there's a difference between them. So I can tell you that people have worked on looking at, you know, the different what's the word I'm looking, physical properties that can happen and the stresses that can happen. There have been for breast cancer especially, there are discussions of should we think about whether or not there's elasticity here and whether they're wearing a bra, and like there's a lot of different things that can happen mechanically in the breast alone, which makes it complicated. So in this model, no, we just have diffusion of the cells. Technically, yes, they can go into those necrotic areas as well. There's no limitation there. And that's really all I have, so I'm happy to say questions. I have to acknowledge all of these people that have been part of this, collecting data, processing data, all of the things, a few of the graduate students. This is Anna, just so you know. This is Tom, my postdoc advisor. This is David, the other postdoc that I was helping do the angiogenesis model. And all of the funding to help make this possible. And thank you to you for allowing me to come here and share. And I'd love to take your questions if we have time. Yeah. Yes?
So I have a question about the vascularization. Is any of the model accounting for the 3D shape of these vessels?
Not right now, no. So what we have is that Caddy-Toff's model, which really just tells us about the perfusion of the drug through the tissue. We're not actually getting a shape of the vessel. This is part of the issue when we're going, like I said, we've done this in the preclinical model, where he can take a much more high-resolution scan to kind of get the vessel structure. But we're in this group, actually it's Chenua here, that is working on a protocol with MRI called ultrafast something, and what she can do is actually create a 3D rendering for clinical data for these vessels. And the idea is to use that for our angiogenesis model to move forward. So right now, no, we're not taking that into account.
I see.
Mm-hmm.
Thank you.
I remember years ago the John Lowen group who was at Irvine, and David Christini, who used to be at Texas, not Austin, at Indiana.
Yes.
So they were developing rather complicated models in which they were creating physical, realizations of vasculature, looking at deformations and so on and so forth. And how are other efforts, this is one that I happen to have heard about, is there a relation, what do other people do? Right?
Yeah,
this is what
absolutely. So it depends on where they're coming from. So I'm trying to remember, Christine, I've definitely read some papers, but read a lot of papers. We've all have, right? I think they were using actual scaffolds from in vitro experiments. Is that correct? Maybe.
What
Okay.
I know is that they actually had generated models for vasculature. So
Okay.
they actually had geometry of how.
Exactly, okay, yeah. So in that situation, you can do a lot of measurements, right? We can figure out the flow, we can figure out what's going on with the geometry, all of these things. It's a lot harder for this case. Like I said, when you have a 5mm slice, that could be a bunch of different vessels right there in that one voxel. So unfortunately, we also have to keep these scans under 20 minutes because that is the clinical time for a breast cancer MRI scan. And remember, insurance doesn't cover this either. It's extremely expensive. So we have to do all of that ourselves. I can tell you I've been a guinea pig many, many times in the MRI scanner to get that protocol down to 20 minutes. However, like I said, Chenua is working on a method that we can really look at those vessels, and the hope is that we can leverage information from in vitro stuff in vivo stuff even too, those models that have already been developed to understand the way that the drug is getting into the vessels. So that's our hope. We're not really trying to build new models if we don't have to, right? We want to leverage stuff we already know.
Just going back then.
Yeah.
First question. Is there any, would there be any advantage at least from modeling in replacing your dynamical systems by stochastic such regulation?
Yeah, that has been discussed. There's some things that they're trying out at the in vitro scale. We have a multi-scale model. I haven't talked about it here. It's an agent-based model actually, where they have stochasticity and whether or not the cells are going to proliferate or whether they're going to move based on the vasculature within it. So we've looked at some of that stuff. It's just at the clinical scale, it's already hard enough to calibrate these things. So we kind of avoid adding more unknowns. But yes, that's definitely part of it. And especially if we get into discussions about persistence and resistance of cells, there's a question of whether or not cells are inherently resistant, genetically resistant, or are they switching phenotypes? Is that stochastic or is that sensed? What are they doing? Why are they switching? Could there be lots of different phenotypes? So that's where some of the stochasticity stuff will come into play for sure, once we can measure it. Mm-hmm. Which I can say there are models out there, just not necessarily supported by a lot of data.
Thank you again.
Okay.